Ladies and gentlemen, welcome to Clinical Journal Club this week, first in English. And the image from the New England Journal is shown here. And I'll just have you take a look at it for a moment. And we're asked, this is a 66-year-old woman who apparently has an upper respiratory infection and goes to an emergency room. And we see these two images. And in my time, the most common cause of this problem was that the intern put the films up on computers, and these are now read on flat screens. And what we can appreciate is that in the PA view of this 66-year-old patient's chest, his heart is on the wrong side, and his aortic knob is on the wrong side. This prompted the doctors to do a CT. And what we see here is that the liver is on the left side and the spleen is on the right side. And there's a kidney on each side, and etc. And so this is not tuberculosis. And this is not a lymphoma. And this is not sarcoidosis. This is situs inversus totalis, which happens in several different forms and severities. I've seen several patients like this. The poor patients are generally maintained in the hospital, and every medical student on the planet has to examine them, and because they're wonderful and it's a whole lot of fun to be confronted with this problem. So we'll take a look at it. This is situs inversus totalis, which means that the right-left inversion is 100%. And now we know the molecular mechanisms that are responsible for this. There are several, and one of them concerns mutations in genes that are molecular motors, dyneins. And these are complexes that make little filaments, hairs, flagellae, and almost all our cells have these. And this is how situs inversus. It can be total, it can also be partial, only involving the heart and not involving the abdominal organs. And some of these patients then have cilia problems and are not able to secrete mucus properly and get sinus disease and bronchiectasis. And that constellation was described about 100 years ago and is called Cartagener's syndrome after the first describer, 1897, as I see here. Now, this patient's electrocardiogram was not shown, but I wanted to show you one of these. This is a German electrocardiogram, so it's recorded at 50 millimeters per second instead of the North American standard of 25 millimeters per second. But what you can see is that AVR is upright, and all the other leads are negative, indicating that the main QRS vector is going away from all these other leads, which shouldn't be the case. And what we also see is that the P wave in lead 1 is upside down, indicating that the P wave vector is also going in the wrong direction. And if we do a bunch of chest leads on these patients and put the chest electrodes on the left side of the chest, then all the vectors that we see will be going away from these leads, and they'll all be negative. And if we merely do a limb reversal on the limb leads and put the chest leads on the other side of the chest, then the electrocardiogram would be normal. Now, the situation where the organs are properly placed is called situs solitus. And what sinus solitus, I don't think that exists. I think the questioners made that up. So this is an example of situs inversus. Now, the first topic in the New England Journal involves a little geography lesson. So in order to appreciate the studies that I'm going to show you, you have to know where Mali is. You have to know where Burkina Faso is. It's right below Mali. These are landlocked African states. Then there's Niger, very poor landlocked African state that's next to Mali. And then there's Ethiopia that you can't see on this picture because it's actually a little southeast of Sudan. So these are the countries that the studies that I'm going to show you deal with. And the story here started actually in Ethiopia in a paper that was published in 2009. And what was done here is that a macrolide antibiotic was given to Ethiopian children in order to, as a prophylaxis against trachoma, which results in blindness, as you know. And To the surprise of the investigators, the survival of children in the azithromycin group was 100% greater compared to the children that got placebo, although trachoma isn't lethal, so that could not have been the effect. And this remarkable paper that was published in 2009 has led investigators to again test the notion if azithromycin could be some sort of wonder drug that keeps children alive. And one of the hypotheses is that the presence of azithromycin might decrease malaria that in essence these children all have on a periodic basis. So in this first study, the children were randomized, households were randomized, not children as individuals, but households were randomized to an antimicrobial treatment, included malaria prophylaxis and several other things, with or without concomitant azithromycin, to again test the notion that azithromycin, through some magical effect that I don't understand, would improve the survival in these children. And what we see in the first study that involved Mali and Burkina Faso, we see that the events, which were a combination of death or hospital admission that was not due to trauma or elective surgery, was actually higher in the group that got azithromycin, 250 episodes compared to 238. And the driving factor here was what happened in Burkina Faso, where this difference was substantially greater in the azithromycin group compared to the placebo group. Aside from that, the primary endpoint was not significantly different, as we see here expressed as events per 1,000 children per year at risk. The group that got the azithromycin in addition to these other agents was no different than the group that got the other agents in placebo. And there were a number of things that these children were given. There's a sulfa drug and pyrimethamine, and this is all basically malaria prophylaxis plus or minus azithromycin. So if we look at the incidence of clinical events, there were no significant differences in terms of most of these variables. But if we look at it carefully, it does look like in the azithromycin group, the appearance of gastrointestinal infections and other bacterial infections was better than in the group that didn't get azithromycin. So if we're going to try to explain some advantage of azithromycin, it might be related to these particular infections. I was also interested in nutrition because as you know, antibiotics we give our livestock antibiotics, and it looks like the clinical nutrition might have been a little better in the azithromycin group compared to the placebo group. Now, there was no difference in malaria parasitemia, so any advantage of azithromycin doesn't concern the appearance of malaria. So that was the first study. Again, the investigators did note that these gastrointestinal infections and respiratory infections were less in the group that got azithromycin. Now, in the second study, this is a French study, and it was performed in Niger. And there are two phases of this study, Mordor 1 and Mordor 2. I thought it was murder, but it's Mordor, so it's Mordor. And so, again, this is a randomization of malaria prophylaxis and other agents plus or minus azithromycin. And in Mordor 1, what we see here is that the mortality rate of the group that got placebo in Mordor 1 was higher than the group that got azithromycin, reminiscent of the results of the Ethiopian study that I mentioned to you. Then in the next phase, in Mordor 2, they just gave all the kids azithromycin, and what happens is that the trend in the placebo group then parallels the group that got azithromycin. So the results of this study would perhaps support the idea that azithromycin would have some additional survival effect in these African children, although the first study didn't seem to indicate that. So there was a decrease in mortality in Mordor 2, and that decrease is 13.3%, which is statistically significant, but that's not what happened in the first study that I showed you. So I'm not certain how to interpret this. One of the things that we might consider is that if you give kids azithromycin, you might encourage antibiotic resistance. And indeed, in one of the Mordor studies, this was studied. And indeed, the kids that got azithromycin just routinely at periodic intervals, indeed developed a resistance to macrolide antibiotics. That's shown here. The relative risk was substantial of developing that was substantially higher. And by rectal swab, looking at resistance organisms there, that was also the case. But fortunately, the appearance of resistance against other non-macrolide antibiotics wasn't a problem, and resistance to rifampicin also did not seem to be a problem, which is strictly speaking also a macrolide antibiotic. So I don't know what this is going to do to the azithromycin policy in this part of Africa. An editorialist comments on this, and one of the possible answers to the effects that we saw in the second study are related to a statistical phenomenon called regression to the mean that was first described by Francis Galton in the late 19th century. Now, the next paper in the New England Journal involves a diabetes study that was started over 17 years ago. And this was a study in type 2 diabetic patients where this is a VA-based study where the patients were randomized to intensive glucose-lowering therapy compared to what we call usual care or casual glucose-lowering therapy. Now, you'll have to recall at the beginning of the 21st century, the drugs that were given to these poor type 2 diabetes patients were mostly sulfonylureas, metformin's high on the list. Some of them got pioglitazone, and then those that needed it also got insulin, and the intensive group got just more of these agents than the usual care group. So that the agents that we now read about for the treatment of type 2 diabetes mellitus did not appear in this study. Now, what was tested here is that, and this is American jargon, you'll have to pardon me, the glycemic legacy effect. And it stems from studies in patients with type 1 diabetes that were also randomized to intensive glucose-lowering therapy compared to a more casual approach to their medical care. And in the type 1 diabetics, it looked like there was a carryover effect after the study was done and their blood sugars went back up to the placebo group. They still seemed years later to have an advantage in terms of diabetic complications. So this was basically a study to test the hypothesis that this glycemic legacy effect might exist in these type 2 diabetes patients as well. And we're interested here primarily in atherosclerotic events or deaths from cardiovascular disease, amputation, congestive heart failure, non-fatal stroke, fatal stroke, and composite of these outcomes. So if we look at the patients, they look like a bunch of type 2 diabetic patients. They have a body mass index of over 30. Most of them are hypertensive. Some are still smoking, and they have glycated hemoglobin levels of 9.4, so they look like US type 2 diabetic patients, and their lipids correspond to their disease. GFR was maintained in these patients. And what we see here is that the intensive therapy group actually did pretty well. Investigators did a pretty good job on them, got their hemoglobin A1C levels down to about 7% compared to standard care, which was 8.5%. Then when the study was over, everybody sort of regresses to usual care. And what we see here is that the primary outcome, a major cardiovascular event, didn't seem to indicate any holdover or carryover effects. The intensive care patients at the end of 15 to 17 years didn't do any better than the patients that got usual care. And there were secondary outcomes, deaths from cardiovascular causes, deaths from any causes, health quality of life, etc. No statistically significant differences here. And if we look at the primary outcome, and this is not a big difference, but the intensive care patients did do a little better than the standard care, and this effect is still detectable at 10 years, but at the end of the study period, between 12 and 17 years, some patients went out 17 years, as you see here. There's no difference comparing these two groups. So if there is a holdover effect, it certainly doesn't hold over very long. This table shows the effects of on major cardiovascular events during the period of separation, and basically it's a negative study. Now, in the supplemental appendix, I did find out that the BMI levels were higher in the intensive care patients than in the usual care patients, and they stayed high throughout the duration of the study, and all these other variables look about the same. Now, the next topic at the New England Journal, again, is chronic lymphatic leukemia, which is a malignant cancer of lymphocytes that is most common in patients that are older than the age of 50, and then there's a steady increase in incidence of this disease until life expectancy is over. And we can diagnose this from the peripheral smear. These are fairly large lymphocytes, which would suggest to me as a non-hematologist that this might be a little more aggressive than if we just saw a sea of small lymphocytes. And as we see in this patient, the spleen is markedly enlarged. It extends down into the pelvis here on the left side, and lymph nodes are enlarged. And then we now know that in CLL, there are a number of mutations that also have a bearing on how aggressive this disease is and what ought to be done about it. Now, the treatment that has been around for 50 years is chlorambucil, or some other alkylating agent if you prefer, but currently chlorambucil is what's given to these patients. Now, the topic here again involves BCL2, or the family member of BCL2 that keeps cells alive rather than encouraging apoptosis. So this particular BCL2 would potentially be a drug target, so that if the leukemia cells have this BCL2, if we block it, then caspase activation might occur, and these lymphocytes would be driven into apoptosis. And there's a drug that does this. We talked about this last week, called venetoclax. And venetoclax binds to BCL2 and encourages these cancer cells to hopefully curl up and die. And here's a picture of BCL2. So in this particular study, what was done is these patients with CLL were given chlorambucil wait a minute, am I correct here? No, they were given, they were given chlorambucil, and some got an antibody against CD20. This is not rituximab, it's called obinutuzumab, but it's basically the same idea, an antibody directed against CD20 that's expressed on lymphocytes. Half of the patients got venetoclax to address BCL2, and the other half just got chlorambucil and the CD20 antibody. So here are the patients, and there are 216 in each group, and various mutations that they have, and whether or not P53 is mutated, and this particular factor that I've forgotten what this abbreviation stands for, so you'll have to look that one up yourself, but it plays a big role in CLL. And what we see here is venetoclax does a pretty good job on these patients, and this is progression-free survival. So this is a good deal, and this is over about 3 years, and the group that got venetoclax did quite a bit better than the group that got chlorambucil and the anti-CD20 antibody, which is now the standard care for patients with the CLL of this aggressive designation. So progression-free survival assessed by an independent review committee. They're supposed to be more honest than the doctors taking care of the patients, but they came to the same conclusion. And the treatment response, complete remission, is what we'd like to see. And that occurred twice as often with venetoclax compared to the group that got chlorambucil and the antibody. And this treatment was pretty well tolerated, I think. You can look at the details on this table, but fatal grade 5 events, 5 in this group, 4 in that group, doesn't look too bad. And well, nothing's absolutely free. So there have to be some problems with this. And I've forgotten exactly what the problem, I think it has to do with neutropenia, and have to check that one out on your own. But I think the treatment all in all was pretty well tolerated. Longer progression-free survival, superior care, median age of these patients is 72 years. So it looks like a pretty good deal. The next topic in the review in the New England Journal involves stem cells. And I'm not just talking about garden variety stem cells, I'm talking about cancer stem cells. And in the last 20 years, the idea of how malignancy comes about has been largely redirected. We're used to looking at cancers that appear in differentiated cells, or cells that ought to be differentiated, like colon cancer or breast cancer or the leukemia that we just looked at. And the idea here is that actually cancers begin as a problem of stem cells rather than more differentiated cells. And the reasoning here is that we need stem cells, and some tissues proliferate at an astounding rate. For instance, we replace our entire gastrointestinal tract every 7 days. And this occurs from stem cells that drive this problem, because our other cells, non-stem cells, can perhaps multiply 30 times at most before they go into senescence. That's called the Hayflick limit. But stem cells can in essence go forever. And so the question that's asked in this review is, why should such a seemingly inefficient mechanism of tissue homeostasis, in which only a few cells are ultimately responsible for fixing damage, those are the stem cells, be used by long-lived multicellular organisms like us? And the answer is probably to reduce the incidence of cancer, because the differentiated cells have a high risk, basically, of perhaps going into malignancy because of what goes on in them, and because their presence in such a huge number compared to stem cells. So the thinking about how cancer comes about is now directed at stem cells, cancer stem cells. And since cancer cells can arise from multiple oncogenic mutations, a tandem series of mutations, one occurring after the other, the odds of a cell accumulating all of the mutations needed for oncogenic transformation are drastically reduced if only a few replication-competent cells in a tissue survive for the duration of a person's life. And our stem cells, I guess, stay with us forever. And this was first worked out with hematopoietic cells, where there is a hematopoietic stem cell, perhaps not quite as potent as an embryonic stem cell that can make anything, but these hematopoietic stem cells can, in essence, become multipotent progenitor cells and then make every cell that your bone marrow is supposed to make, including platelets and erythrocytes and granulocytes and monocytes and T cells and B cells. And so the problem directs our attention here, where there are relatively few number of cells responsible for the production of all of this stuff. And the investigations here really began after the end of World War II, when observations were made in patients in Hiroshima and Nagasaki that had been exposed to radiation, where hematologic malignancies suddenly became much more common. And so this review goes through all of this stuff and how stem cells that have self-renewal genes, their roles, downregulation of differentiation, then become early progenitors where differentiation genes are then upregulated, and late progenitors, adult cells in essence, where the self-renewal genes are not necessarily downregulated and disappeared, whereas the differentiation genes are expressed at a high degree. The genetic mechanisms that are involved here so that cells can proliferate forever involve telomerase, so that the telomeres are reconstituted, and a whole bunch of epigenetic regulators. And here's an example that was discovered in AML. And that's the discussion here of how these cells then become pre-malignant stem cells, and genes that are involved here result not only in cancer but also in other chronic diseases such as atherosclerosis. We've looked at TET2 in New England Journal papers, and mutations in TET2 are associated not only with malignancy but also the development of premature atherosclerosis, indicating again that we're dealing with a wide systemic problem that involves across clinical divides, basic mechanisms. And that's what this paper is about. And models that are here, a single mutation, then a pre-malignant clone, and then the development of a tumor, and we treat the tumor, and we're not in a position with the current therapies to get this stem cell, whose mutation probably involves telomerase TERT or some epigenetic problem that's not even expressed in any of these more differentiated tumor cells that we address with our current therapies. Now, the second review in the New England Journal involves the opioid epidemic. Now, I realize this is a favorite axe that I like to grind. This whole opioid epidemic business started about 30 years ago when certain groups, primarily pharmaceutical companies, came up with the idea that pain is the fifth vital sign. And another idea here was to include the patients in decision-making about their care. So this is spread across the United States and Europe and is probably impossible to kill, but this is basically an abstract of a paper suggesting that some societies, including the American Medical Associations, the American College of Surgeons, and American Academy of Family Physicians, have withdrawn their advocacy of as pain being the fifth vital sign. Because basically what happens here is the patients always say either this or this, and when they do, they're treated with pain medicines. And the pain medicines that are given for this level of pain are commonly opioids, currently most commonly oxycodone. And I've already mentioned to you that Adolf Hitler's favorite medicine was oxycodone. I admit he liked amphetamines and putatively also tried cocaine, but in order to deal with those problems, he loved oxycodone. And the man that wrote the review that I'm going to show you says all opioid overdoses share a common characteristic, the first opioid exposure. And the idea would be to keep opioid naive patients opioid naive and to not start in this chain of events. But he doesn't quite have the courage that this should be abandoned. But the review is nevertheless very worthwhile reading, because the editorialist points out that in the time it takes to read this review, somebody will have killed himself with opioids in the United States. And the chances that this will happen includes a number of different variables, including also the age of the patients. So if we're dealing with children or adolescents, their chances of becoming opioid dependent are substantially greater than for older adults. Also, if the opioids are prescribed for more than 5 days, the chances of becoming opioid dependent go up incrementally. And 10% of opioid prescriptions are given for 30 days. And some states in the United States have developed prescription drug monitoring programs where patients have to allow themselves to be tested in terms of what they're taking, but that's not true for all states. Then there's a scale to help physicians decide who's going to stop breathing, because not all opioid deaths are necessarily suicides. Some of them are just mistakes and stupidity, because the patients are concomitantly getting other things, like alcohol or benzodiazepines or antidepressants or other medications. And this table here shows that this is in essence the Rio sword scale, which patients have a risk of developing apnea when they're subjected to opioids. And you can go over all these clinical variables. And then what do we do with the patients that are hooked, and what are the chances of instituting a tapering program? And what's the role of buprenorphine or methadone in treating these patients? And various clinical aspects are discussed here, but this is a major medical problem that didn't even exist when I went to medical school. It's also present in Europe, and we need to know something about it. Here's this patient from last week with a hole in his tongue and these coccidiomycosis spherules, and all these things were treated, and he got all better, and his HIV viral load became undetectable, and then he was lost to follow-up. Common story. Also in the New England Journal is more detail on this patient that we discussed last week. This has to do with this 29-year-old woman that has systemic lupus erythematosus and pretty bad renal disease, with half of her glomeruli are crescentic. And she comes in with diarrhea on her current treatment, which includes mycophenolate mofetil and other agents directed to treat her lupus erythematosus. And the clinicians are confronted with the problem of what is causing the diarrhea in this patient. And because the patient is immunosuppressed, Clostridium difficile would be high on our list, although there are also other possibilities, including other bacterial infections, cytomegalovirus, or even, not commonly, but mycophenolate can also induce diarrhea. So we're showing all our laboratory values, and actually our C. diff testing was negative. That was the first question that we were asked, and the first problem that we have to rule out is whether or not she could probably have Clostridium difficile. That was done. Then, while this patient is in the hospital, she suddenly lapses into coma. So now we have a problem of diarrhea plus coma in this patient. Then this kindly neurologist comes by, and he determines that she has a positive Brudzinski sign. You may have forgotten Koenig's and Brudzinski's signs. If you have, we'll just remind you. And you'll recall that Koenig's sign involves whether or not the patient can extend at the knee while the hip is fully flexed, if the knee can be completely extended. So our patient could do this, but the other test is if you just raise the back of the patient's head off of the mat, and a positive Brudzinski sign is flexion of both legs and thighs. And these two tests indicate meningeal inflammation. So the next step is this patient obviously needs a lumbar puncture. And then the question was raised, should she have imaging before the lumbar puncture is done? And I would have guessed no, but apparently the standard now is if the patient is immunosuppressed, you're supposed to do imaging before a lumbar puncture is done. So in this patient, here's some imaging, and here's an MRI of her head, and she's got thalamic swelling. that doesn't help us too much. I would guess that probably votes against herpes simplex encephalitis because there I would expect temporal lobes to be involved. But at any rate, she needs an LP. But she's treated with antibiotics and acyclovir anyway, but an LP is done, and then we went over what the findings are in viral encephalitis, a little bit of protein elevation and a little bit of white cell elevations, but not necessarily neutrophils and a negative gram stain, etc. No erythrocytes, or at least very few. And then we discuss West Nile virus infection, which this patient had. And I didn't really appreciate this, but West Nile virus has ended up being a major problem in the American Midwest, and it's pretty common, and it's spread by mosquitoes. And this patient is an example of West Nile encephalopathy. Now, there's no treatment available other than supportive care for West Nile virus. Immunoglobulins are sometimes given, but there's no evidence that these have particular clinical efficacy, but she got all better and went home. Now, in the Lancet, the first topic is inhibitors of Janus kinases, or JAKs. The abbreviation is actually for Janus, the Roman god that has sort of a face on both sides of his head, because these kinases are expressed bilaterally on cytokine receptors. For instance, erythropoietin is a cytokine. And once the cytokine docks in the receptor, these Janus kinases phosphorylate the receptor, and a chain of events happens that involves intermediary proteins called STATs. So we call this JAK-STAT signaling, and then basically factors are formed that can move into the nucleus that turn certain genes on and off. And so if your disease involves inappropriate behavior by cytokines, then maybe a JAK inhibitor could possibly help you. And indeed, there are a host of inflammatory diseases. We've looked at some of these. Crohn's disease is an example that are helped by JAK inhibitors. And in this example that we're going to look at rheumatoid arthritis, which we now have a whole bunch of treatment options for rheumatoid arthritis, but one possibility would also be JAK-STAT pathway inhibition. And rheumatoid arthritis patients are evaluated in terms of the American College of Rheumatology has made up scales that consider a whole host of variables so that we can look at a bunch of different variables, including lab tests, to assess whether or not the rheumatoid arthritis patients are getting better. And then we can grade them in terms of have they at least got 20% better, or have they get 50% better? Are they almost into remission and got 20%, 70% better? So the ACR response criteria, if you're a rheumatologist, you know all this by heart, but we need to be familiar with this. So in this particular study, these are rheumatoid arthritis patients that would otherwise be treated with methotrexate, and we could consider the possibility of treating them with a JAK-STAT inhibitor, upadacitinib. Can't even pronounce it, but so JAK-STAT, we know how that works. Cytokine signaling inhibitors, JAK inhibitors. So the patients got they either got methotrexate or 2 different doses of this JAK-STAT inhibitor. And so patients are primarily female. Patients came from various places around the world. Some of them had rheumatoid, most of them were rheumatoid factor positive, and a number of different scales are used to evaluate these patients, but the endpoint was the American College of Rheumatology scale. So if we look at how many got 20% better, it looks like the JAK-STAT pathway inhibition beats methotrexate. This other scale was also used, and the results of this other scale were the same. So if we look at the responders here, the patients that got the JAK-STAT inhibition did about twice as well as the patients that got methotrexate alone, irrespective of the 2 scales. And some of the patients got a whole lot better and had a 70% ACR response compared to methotrexate, where that hardly ever happened. And so there were various other grading criteria that were used here. And serious adverse events, methotrexate is pretty safe, but the JAK-STAT pathway inhibition was about the same. And so it looked like side effects were manageable. So this is the first study, to my knowledge, that looked at rheumatoid arthritis as a possible disease that would respond to JAK-STAT inhibition, and it certainly did. The next topic at the Lancet concerns assessment of nutrition, and this is done by the Subjective Global Assessment Score. You can load this down off the internet in any language that you wish, and then usually ancillary personnel can fill out this form so that you can get some idea about whether or not your patients are poorly nourished, catastrophically poorly nourished, or pretty much okay. Now, this study, which I think is an important study, tested the hypothesis that patients that are marginally or poorly nourished might do better if, while in the hospital, if they're in there for at least 4 days, somebody paid attention to their nutritional status. And the first thing that I did was look to see who sponsored this study, because there's a woman in the United States, she's a professor of nutrition. Her name is Marion Nestle, she pronounced it, although it's spelled Nestle, like the food company that's based in Switzerland. And Marion Nestle wrote a very critical book indicating that anything that's sponsored by the food industry is probably crooked. I think she may have a point, but this study was funded by the Swiss National Science Foundation and not by any food companies. So what was done here is that these patients were assessed by the Nutritional Risk Screening Scale, which here's the German version, and you can just scratch the little boxes here, including calf circumference and upper arm circumference and various other criteria here. Some are objective and some of them are also subjective, and then body mass index and these various other things. Plug that in to see whether or not the patients would be eligible for participating in this study. So the investigators screened 5,000 patients and then assigned, and 2,000 were marginally or poorly nourished, and so they assigned them to an intervention group or to a control group. And what's shown here on the left side, and you can look at this in your leisure, is what was actually done to these patients. But what they did was do the patients reach their caloric intake goals? And do they reach their protein intake goals? And the intervention patients are the red people, and the control people that just got whatever the hospital offered to feed them are in blue. And what we look here is that there were positive outcomes, adverse outcome within 30 days. And their Bartlett scale, which is a scale that you can assess particularly geriatric patients, whether or not they can take care of themselves, whether or not they're stool continent, whether or not they're bladder continent, whether they can get up, whether or not they can climb stairs, etc. The Bartlett scales improved in the patients that received the intervention. And so we look at was there an adverse outcome? Well, only if you were in the control group. So it looks like attention to nutrition might offer these patients something, and it was shown pretty much across the board in these patients. The next study in the Lancet involves a randomization of patients that have cholecystitis to sending them to surgery, or a more watchful waiting kind of approach. Now, we have excellent operations for cholecystitis, and patients that have gallstones, that have had episodes of cholecystitis, the recommendation is currently a laparoscopic cholecystectomy because the risks are low and the chances of recurrence are high, and looks like a good treatment. So that's what the control group got. And the intervention group here got a little more antibiotics and pain medicines, and it was a little more conservative approach that was shown here. So here are the patients that are randomized They couldn't have complicated cholecystitis, and they couldn't have cancer, and they couldn't be pregnant, and they couldn't have hepatic cirrhosis, etc. And these patients were randomized to usual care, and where the physicians made a judgment, and most of them went to surgery, compared to a more conservative sort of pain management, wait and see, antibiotics, let's see what happens. And what basically happens is that both groups did pretty well, but the number of operations were reduced with the more conservative approach by 17%. So usual care, restrictive care, it looks like the restrictive care patients had a little more pain. Yes, that might, severe pain in attacks. They just had to tough it out. I don't know if they filled out their smiley faces or not, but the differences you can look at here in detail, but it looks like free from pain was a little bit better in the usual care group, but looked like it was tolerable, and health status over time was the same in both groups. So perhaps if you have very good health care, the way they do in the Netherlands, maybe a more restrictive approach would be appropriate. Now, the reviews in the Lancet are about lupus erythematosus. This is a systemic autoimmune disease that involves a production of a whole host of different antibodies, but including antinuclear antibodies against double-stranded DNA. It usually begins as a skin disease, and a malar rash, so-called butterfly rash, is common, but connective tissue all through the body is involved, and the kidneys are commonly involved with glomerulonephritis. End-stage renal disease can result, but the heart can also be involved, the lungs, the musculoskeletal systems, and of course, arthritis. And so the first review concerns management strategies and what the future directions for SLE might be in adults, and that's shown here. And they look at the incidence of SLE across the world in these publications in various different countries, and it seems to be pretty much about the same, although lupus is a little more common in Black people than Caucasians, and it's probably also a little more common in Minnesota and Sweden because the doctors are looking for it, and in Michigan compared to other places in the world. And joint pain, joint involvement, renal biopsy would have to be done to classify this precisely. Hematologic anemia, LE cell phenomena, neurological lupus, immunological things can be categorized here. These people still need to be vaccinated. They need ultraviolet avoidance. They should stop smoking, but that's true for everybody. We have to think about their vitamin D status and these various things, antiphospholipid antibody syndromes, etc. So then there's a management strategy that physicians should consider here stepwise, and the next review goes into even more detail, primarily what the Europeans do with these patients depending upon the severity of their diseases as indicated on these various tables, and then whether or not the problem involves only skin disease, and whether or not it's more systemic, and whether or not corticosteroids should be given, and mycophenolate mofetil and other immunosuppressive drugs, and also investigative agents. And now we know that there are a whole bunch of biological agents that we can also give these patients, including a new antibody, belimumab, that we've discussed in this exercise before, that involves a factor that's expressed on B cells, the so-called B lymphocyte stimulator, or BLIS, which seems to offer these patients additional advantages, which is being investigated. Rituximab is also represented in various agents that can be given to these patients. So there are a whole variety of treatment options that should improve the outcomes of these patients so that we don't have them on dialysis. Here's a patient from Japan. He's not happy, so he's not smiling. We've discussed this issue already. This is an 80-year-old Japanese man who comes to the hospital with a 3-day history of stiffness in his jaw, difficulty moving in his right arm, and the doctors initially have a little bit of a problem in figuring this out. Basically, and this is basically a clinical diagnosis, this patient has tetanus, and they give him immunoglobulins against tetanus, and he gets antibiotics, and eventually I think he has to be put on a ventilator for 21 days, and it's terrible. And this condition has a mortality of over 50%, and since it can be avoided completely with a vaccination, it's almost inexcusable, and I don't know how this 80-year-old Japanese patient avoided getting vaccinated. Because to my knowledge, at least the issue was reviewed in Science several weeks ago, the vaccine against tetanus confers resistance for life. So we don't need to see this anymore. But basically what happens here is these tetanus toxins attack snares and snare proteins, which are involved in vesicular transport of signaling molecules like glycine and GABA that are necessary that act as neurotransmitters in the cerebrospinal cord and in the brain. And actually, this is quite similar to botulism toxin, which is another toxin made by Clostridium bacteria that runs over snare proteins. That's it for this week. Join me next week and we'll see what they have to offer us at that time.